Hello, welcome back to Pharma Training Solution. Today I will be briefly explaining antibacterial agents and specifically the cell wall inhibitors. Now, of course, let me first briefly define these terms. Antimicrobial agents, because this is any chemical or drug used to treat an infectious disease. Now, antibiotics, which is synonymous with antibacterial these days, is a substance that produced by a microorganism that kills or inhibits growth of other microorganisms. Because this is how they were discovered by Alexander Fleming through that mold which was near a bacteria, and it caused a circle of eradication of some of the bacteria. Now, however, today most of them are semi-synthetic or synthetically synthesized within the lab. So what are the goals of antimicrobial therapy? We have prophylaxis, because we know it, preemptive in high-risk patients, empirical, this one is the common which is practiced today, treatment of infection before specific culture information when you receive a prescription having bacterial infection. What is bacterial infection? Now, definitive therapy, this one is treatment. If you have specific culture information, you mean that you'll be treating specifically to as the culture tells you. But today, of course, we don't have definitive data, so we use empirical treatment. However, it is always important to have definitive culture. Now, which are the properties of an ideal antimicrobial agent? One is selective toxicity. Should kill the microorganism only. Selective toxicity to the microorganism. We have another one as non-allergic to the patient, low incidence of side effects or toxicity to the patient, and preferably inexpensive. Now this one, this is subjective. I don't know why I put it here. Easy to manufacture. Let me talk about easy to manufacture. Let me talk about cost. Should be easy to produce, and very many other properties. Now, what are the effects of antibiotic therapy? One, of course, is cure if the organism is susceptible to the drug when they are killed, or development of allergic reactions, penicillins or sulfur-containing antibiotics such as sulfonamides, and other side effects, especially the GIT side effects. Remember, we shall not be talking about nausea and vomiting, diarrhea, abdominal pain. We shall be talking about GIT discomfort or distress as the side effect. Now, of course, with prolonged use, they can also destroy the normal flora within the GIT, leading to super infection. I'll show you a way of that. Now, resistance to antimicrobial agents. I'm going to have another presentation where I will explain in detail all this slide. We'll have one of polypharmacy, anti resistance and self-medication. I think also pharmacovigilance. I'll research more on those and I make more presentations on those ones. So show you now to define the causes, the types, and the consequences of antimicrobial resistance, because this one is very important to know before you start dispensing these medications. Now, which are those mechanisms of resistance to antimicrobials? One is reduced entry of the antibiotic into the pathogen, enhanced export out of the antibiotic by the efflux pump. These bacteria have developed efflux pump which pump out the antibiotic. The other one is production of enzymes that alter or destroy the antibiotics, such as the beta-lactamase, the penicillins, alteration of the target proteins, the alternative pathways. If this bacteria get alternative pathways, especially the folic acid synthesis pathway. Now, our goal as health professionals should be tailored towards antibiotic stewardship. Or what do I mean by stewardship? Meaning appropriate use of antibiotics, because these are the gold of today. Imagine all of the antibiotics we developed resistance. What would happen to the nation, to the world? So, as health professionals, we'll be talking about stewardship. I'll explain more in this one in our preceding presentation. Now, Classification out. That will be, I'm going to talk about the cell wall inhibitors. Others, they're in other presentation which are coming. Penicillins, of course, penicillins are bactericidal cell wall synthesis inhibitors that enter the bacteria via the cell wall and bind to the penicillin binding protein, disrupting the bacteria cell wall. Now, the bad cell wall is so much repeated, but it is very important to know. Most of us only stop on cell wall synthesis inhibitors, but what is that? They bind to the penicillin binding protein and disrupt the bacterial cells and cause death through cell lysis, or they cause pores in the cell wall and leakage of the bacteria, the ions, or those important organelles, and they cause death. That's what causes the bactericidal effect. Remember, bactericidal is kill, and bacteriostatic is you inhibit the growth, and the human system takes over. Now, how do we classify penicillins? Of course, penicillins are classified. One is narrow spectrum beta-lactamase susceptible agents. Most of us always stop on narrow spectrum, venal spectrum, broad spectrum. What is that? They're classified as narrow spectrum beta-lactamase susceptible agents. Examples we have natural ones. This is penicillin G or penicillin. Also phenoctemycyl penicillin, or what we call penicillin V. Very narrow penicillinase resistance or beta-lactamase resistant agent. Now, nefticillin, oxacillin, chlorxacillin, flucloxacillin, these are useful in staph infection. Broad spectrum penicillinase susceptible agents. Ensure I use those terms, not just say broad spectrum. The other one is the examples of broad spectrum. We have Ampiclox, amoxicillin, ticacillin, all those. Ticacillin, piperacillin, these are important in Pseudomonas infections. Now, of course, penicillins are given orally and rapidly excreted via the kidneys. Of course, we know when we go to urinate, we always get that scent or that smell of antibiotics. And 10% is via glomerular filtration. However, 90% is through tubular secretion. Probenecid inhibits tubular secretion and hence reduces the administration rate to twice daily. Now, let me talk about the beta-lactamase inhibitors. One, we have clavulanic acid, tazobactam, and sulbactam. These are usually used in combination with other amoxicillins such as amoxicillin, clavulanic acid. Of course, we know in the pharmacy we have Augmentin, Quamoxclav, Batoclav, and very many other brands. The other combination is ampicillin and sulbactam. Use of penicillin, of course, they use Pen-V is used in minor oropharyngeal bacterial infection, benzazine, penicillin G, syphilis, procaine, penicillin G. So used in pneumonia, gonorrhea. They are also used in E. coli infection, influenza, respiratory infection, ENT, otitis media, otitis infection, and penicillin is also used in triple therapy, in eradication of H. pylori. Side effects of penicillins, we have allergic reactions. Of course, when these allergic, they are very key. Which are those allergic reactions? You have urticaria, severe pruritus, fever, and joint swelling, and the GI distress. Remember, with GI distress are meaning abdominal pain, abdominal discomfort, diarrhea, nausea, and vomiting. We don't talk about, we just said GI distress, because if you list them as side effects, then you don't know what you're talking about. Now, cephalosporin, these also contain a beta-lactam ring, but they are more resistant to beta-lactamases, and they have the same mechanism of action as the penicillin. That's sure you know that one. A classification of first generation, active against gram-positive, the E. coli, strep. Cephalexin is oral, while cefazolin is IV. Second generation, they have less activity against gram-positive, but have good gram-negative activity, especially in influenza. That's why they use it in the respiratory infection. Zinat or cefuroxime, we know it. This is very important. Cefaclo, cefotaten, also very important. Third generation, Cephalosporins we have increased activity on gram-negative. These ones we have cefixime, ceftriaxone, cefotaxime. Now there are other examples which I didn't talk about. I'll show you know them. Now, also what I didn't talk about is the pharmacokinetics. What enters, what causes the blood-brain barrier, what does not, what is given oral, what is given IV by this ceftriaxone is given IV by slow infusion. Why not by fast infusion? So at least ensure you know most of those ones. Fourth generation, these are cefepime, such as these are active against Pseudomonas aeruginosa. Uses of course we have the use in UTI, staph infection, respiratory infection, gonorrhea, UTI, and very many other things in combination with aminoglycosides and all these. They can elicit reaction, allergic reaction, sometimes fever, rashes, and all these. The other beta-lactams of carbapenem, imipenem, meropenem, doripenem, wide activity on gram-positive and gram-negative road. Imipenem is inactivated by renal dehydropeptidase in the renal tube, resulting in low urinary concentration. And that's why it is administered with cilastatin. You know, in the pharmacy we have that combination imipenem, cilastatin, an inhibitor of renal dehydropeptidase. The side effects have GI distress and skin rash. Others we have monobactam, azotrenum. Ensure you know the mechanism and the side effects of these ones. These are very important drugs. Others we have cycloserine using TB, vancomycin. It has this bactericidal action. It inhibits cellulosynthesis by binding to the other peptidoglycan, petapeptide, and is used in gram-positive, gram-bacteria methicillin-resistant staph aureus infection and in septicemia. Even this one they use also in septicemia, all those hard to treat bacterial infections. Bacterial. Now, remember this has been a short presentation on these anti-cell wall inhibitors, but there is more information on especially pharmacokinetics, side effects, contraindication, indication, which you can look for, or you can always contact us. These are the other positions which we have. I always remain Wilson from M Pharma Training Solutions. Always contact us for more information via email or WhatsApp. Leave a comment on how you can improve. Subscribe to the channel in case you haven't subscribed. Like the video, share with a friend, and thank you very much for listening to me and watching the presentation.